Mm, like you've already done a lot of pediatrics already. Doing this again is like really annoying, to be honest. But let's just do it off. I'll just do like maybe like mm, 10 pages and I'll leave it for right now in this one thing. So, okay, pediatric diarrhea. So, acute diarrhea is passage of more than 3 loose watery stools within 24 hours. So, change in consistency is more important than change in frequency of stools. Dysentery is diarrhea with visible blood and associated with fever and tenesmus. Persistent diarrhea is acute diarrhea of infections origin lasting for more than 14 days. Chronic diarrhea is more than 14 days of non-infectious origin like gluten sensitivity and metabolic error diarrhea. So etiologically it can be infectious or non-infectious. Infectious, you have virus, bacteria and parasite. Rotavirus, astrovirus, adenovirus, calcivirus, coronavirus and all will be there, and bacteria E. coli, Clostridium jejuni, Salmonella, Shigella, Cholera, Bacillus. Then parasites can be E. histolytica, Ascaris, Longulolites, Trichuriasis, Trichinella and hookworms, and infections can be Quashiorkor, Sprue, celiac disease and pellagra. Risk factors may be malnutrition, reduced gastric acidity, and immunodeficiency. Pathogenesis, you can have ingestion of toxin, ingestion of organism, bowel colonization, toxin elaboration. All of this will lead to toxin binding to enterocyte receptors. There is increase in intracellular mediators. Then after this increase, there is increase in activation of target intracellular protein kinase and all. There is alteration of protein transport of protein and ion channel leading to diarrhea. So clinical features, you'll find depressed anterior frontal. There will be changed sensorium. Eyes will be sunken and dry, and there is dry mucous membrane. There will be thirst over there. Tachypnea will be there. Skin elasticity will be lost. Abdomen will be distended. There is sudden weight loss. Tachycardia, hypotension, cold cyanosis will be there, and oliguria will be there. Then degrees, you have no dehydration, some dehydration, and severe dehydration. Less than 5, less than 5 to 10, and more than 10. So eyes will be normal, sunken, and deeply sunken. Tears will be present and absent in these. Tongue will be moist and dry in these. Thirst will be not thirsty, but unable to drink here. They'll not be, if they're very severe dehydration, they'll not be drinking. And anterior frontal line will be normal, depressed, very much depressed. Then skin pinch, less than 2, more than 2, more than 3. Treatment is plan A, wherein you have home available fluids. Treatment B is WHO ORS. And treatment C is IV infusion. Complications, you have electrolyte imbalance, which is increase carbs, hypernatremia, you have hyponatremia, you have hypokalemia, and you have metabolic acidosis. So management, you have principles of management. You have rehydration, you have adequate feeding, zinc, and early recognition of danger signs and treatment of complications. Management, you have treatment plan A, which is increasing the fluid intake. Treatment at home after explaining about feeding and danger signs, and WHO ORH will be given. Increased fluid intake will be there. Preferred fluids are rice ganji, barley water, carrot soup, buttermilk, lassi, fruit juice, etc. Then you have salt sugar solution composed of 5 gram, this one fish stool, 3 punches, 1 glass, something like that. 8:1, 6 teaspoon table salt and 1 teaspoon. Dosage can be okay. Diarrhea I'll actually teach from pediatrics. diarrhea treatment. Pediatric marrow. Then you do continuous feeding to prevent malnutrition. You continuous breastfeeding. You give more soft cooked food. You have additional meals after episode of diarrhea. So first signs of dehydration is to prevent acidosis, renal failure, and death. Treatment B, you have oral rehydration solution. Oral fluid therapy, you have fluid requirement is calculated by this formula, which is rehydration therapy is this one, and maintenance of fluid is this much. Indication, you have mild to moderate dehydration and diarrheal diseases, hypovolemia, vomiting, excessive sweating, and inadequate fluid intake. After 4 hours, assess the child for degree of dehydration. If improvement is there, shift the treatment to plan A. If no improvement is there, continue with plan B. If severe dehydration is there, shift to plan C. WHO, you have low osmolarity, ORS, active secretion of NaNCl into the GIT lumen occurs in diarrhea. Glucose is absorbed via sodium glucose co-transporter. One molecule of glucose, 1 molecule of sodium is absorbed together. There is depletion of sodium loss. Osmolarity should not exceed that of blood. Lower osmolarity of gut lumen allows greater absorption of fluid into the bloodstream. WHO ORS is universally used in all age groups with any type of diarrhea. Use of low ORS, you have reduction of stool output, decreased vomiting, decreased use of IV fluid, and decreased risk of hyponatremia. You also have Risomol, which is rehydration solution for malnourished. ORS, high potassium chloride will be there. Honestly, all these treatment plans are very much wrong. Treatment plan, I'll do it again. Zinc therapy, thermogenesis of plasma oxycycline. Prevention of diarrhea, excessive blood feed, exclusive breastfeeding up to 6 months, clean drink water, and washing, use of solvents, and measles vaccine. Persistent diarrhea. Acute diarrhea of infections origin lasting for more than 14 days. Persistent diarrhea starts in infection origin, but prolongation of diarrhea is not entirely due to infections. Idiopathogenesis malnourishment leads to impaired reparative process of gut. You have anorexia, faulty feeding, and lactose intolerance. Explosive stools passed with gas and noise. Cryptosporidal infection associated with infection of UTI and pathogenic E. coli infection. So EPEC and EAEC cryptosporidium cause malabsorption due to persistent infection. Cow milk protein allergy may be there, and antibiotics you can do suppressing the gut flora and overlying of the pathognomic organism leading to persistent diarrhea. So clinical features will be same as above. Growth stunting will be there, and malnutrition will be there. Management, you have correction of dehydration, electrolytes, and hypoglycemia. Even though they pass several stools, they remain well hydrated. Presence of perineal and excoriation in lactose intolerance and explosive stool of hydrogen and unabsorbed lactate. Management, you have correction of dehydration and electrolytes and hypoglycemia. Evaluation of infections using appropriate investigations. You can do hemogram, blood culture, and urine culture. Evaluation of infections. Okay, nutrition 60 feeds and ensure total caloric intake of 100 kcal per kg per day. Gradually increased to 150 kcal per day. Initially, diet A is to reduce lactose diet, second diet B is to lactose free diet, and third diet C is monosaccharide based diet. Diet A is not more than 2 gram of lactose per kg per day, milk plus cereals, milk or curd mixed rice, milk, suji gruel, and proteins and some micronutrients. Diet B is impaired digestion of starch and disaccharide and other than lactose, cereals and glucose, chicken, egg, and protein are hydro. I said. Then you have monosaccharide based diet, only protein, glucose, and protein, egg, chicken, protein, and hydroglyceride. Green unripe banana diet. Resumption of the regular diet after discharge. You have to resume the diet and supplement vitamins and minerals twice the recommended dose, which is more than 2 international unit and 10 to 20 mg zinc, more than 2 lakh international units. Okay. Nutritional recovery syndrome or refeeding syndrome, which is food is introduced too quickly after a period of malnourishment. Shift in electrolyte level can cause serious complications such as seizures, heart failure, and coma. 6 to 7 days total calorie of 100 kilocal per kg is ensured. Calorie intake is increased gradually over 1 to 2 weeks to 150 kilocal per day. To ensure adequate absorption and decrease the stool output, different degrees of carbohydrate exclusive diet is given. Initial diet A, second diet B, and third diet C. Diet A is reduced lactose, lactose free, and monosaccharide base. Same, which is here. Enteropathogenic, hemorrhagic maybe. Portal hypertension, normal portal pressure is 5 to 10 mm Hg. In portal hypertension, portal vein pressure is more than 12 mm Hg. Causes, you have pre-hepatic, hepatic, and post-hepatic. So pre-hepatic, you have portal vein or splenic vein thrombosis, you have periportal inflammation, and you have extrahepatic portal vein obstruction. Hepatic, you have alcoholic cirrhosis, non-cirrhotic portal fibrosis, schistosomiasis, hepatitis, Wilson's disease, and hemochromatosis. Post-hepatic, you have Budd-Chiari, you have congestive cardiac failure, and constrictive pericarditis. Clinical presentation, you have a triad of portal hypertension, which is esophageal varices, splenomegaly, and ascites. You have jaundice, you have hepatic encephalopathy, hysterexis, flapping tremor, or liver flap. Photosystemic shunting will also be there, which is Canavis sign, which is venous hum in epigastrium or louder on inspiration. You have hepatorenal syndrome, which is decreased urine output and renal failure. Hypersplenism you have, and hemorrhoids you have. Complications, you have splenic rupture, hepatopulmonary syndrome, and which has dyspnea and orthodexia. Dyspnea is induced in upright position, reduced in recumbency. Orthodexia is arterial deoxygenation induced in upright position, reduced in recumbency. Investigation, here hemoglobin percentage, anemia due to bleeding and hypersplenism. LFT is raised bilirubin, raised prothrombin, raised APTT. RFT is raised urea, serum creatinine. Ultrasound abdomen is splenomegaly. CECT and MRI is collateral circulation and portal vein status. MR venogram is extrahepatic portal vein thrombosis. Venous pulmonary wedge pressure. Now, venous pulmonary pressure gradient more than 5 mm of Hg. Esophageal gastroscopy identify bleeding varices. Management, you have general measures, correction of anemia. Nutritional supplementation, you do injection of vitamin K, coagulation and correction, blood transfusion you can do. Specific measures, you have treatment of hepatic encephalopathy and treatment of ascites. You have reduced portal vein pressure, surgery, portosystemic stenting and liver transplantation. Mm. 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 Then you have extrahepatic portal vein obstruction, characterized by obstruction of the main portal vein. It is caused most common cause of portal hypertension in India due to neonatal omphalitis, umbilical vein catheterization or sepsis, internal abdominal infection, and hypercoagulable state. Clinical features is generally asymptomatic splenomegaly, hematemesis due to variceal bleeding, normal liver size, and normal liver function tests. Treatment is mesorex bypass shunt across obstruction from superior SMV to PV. Hepatic encephalopathy is there, which is neuropsychiatric abnormalities resulting from liver dysfunction. Mechanism is increased ammonia in blood due to liver dysfunction. Astrocytes use ammonia to synthesize glutamine, and increased amount of glutamine leads to increased osmotic pressure in astrocyte, which becomes swollen. Clinical features, you have inverted sleep-wake pattern, sleeping by day, being awake at night, lethargy and personality changes, asterixis or liver flap, characteristic flapping, jerking movement of limbs, positive Babinski sign and exaggerated tendon reflexes. Treatment is to decrease the ammonia level. You have lactulose, rifaximin, electrolyte repletion is there. Hepatosplenomegaly causes, you have chronic liver disease, metabolic disorders, infection, neoplasm, biliary may be there, and miscellaneous may be there. Chronic liver disease, you have Wilson's disease, chronic hepatitis, autoimmune liver disease, and Budd-Chiari syndrome. Metabolic glycolysis disorders, you have glycogen storage disorders, Gaucher's disease, Neil-Pigman's disease, and non-alcoholic fatty acid liver disease. Then infection, you will have viral hepatitis, tuberculosis, salmonella, malaria, hydrated cyst. Neoplasm, you have hepatoblastoma, hepatocellular carcinoma, and leukemia. Biliary, you have Caroli's disease, colorectal cyst, and congenital hepatic fibrosis with biliary obstruction. Miscellaneous congestive heart failure and constrictive pericarditis. All of these causes hepatosplenomegaly. Wilson's disease, chronic hepatitis, autoimmune liver disease, Budd-Chiari syndrome, glycogen storage disorder, Gaucher's disease, Neil-Pigman's disease, non-alcoholic fatty liver disease, viral hepatitis, tuberculosis, salmonella, malaria, hydrated cyst, hepatoblastoma, hepatocellular carcinoma, leukemia, Caroli's disease, colorectal cyst, congenital hepatic fibrosis, biliary obstruction. All of them can be there. Cirrhosis is diffuse process in liver characterized by cell injury, fibrosis, regeneration, which is nodule formation in response to inflammation, caused due to viral hepatitis B and C, autoimmune hepatitis, metabolic disorders like Wilson's disease, glycogen storage diseases, Gaucher's disease, Neil-Pigman, galactosemia, cystic fibrosis, non-alcoholic steatohepatitis, and alpha-1 antitrypsin deficiency. Venous obstruction, you have Budd-Chiari syndrome, constrictive pericarditis, and congestive cardiac failure. Biliary, you have biliary atresia, Caroli's disease, Alagille syndrome, and primary sclerosing cholangitis. So clinical features, you'll be having failure to thrive, anorexia, jaundice, gastrointestinal bleeding, altered sensorium, ascites, differential lobe enlargement in liver, and liver will be firm and nodular. Applications, of course, portal hypertension, caput medicine, which is tortuous vein, spider angiomata, and hepatic encephalopathy. Then you have congenital hypertrophic pyloric stenosis, which is hypertrophy of circular muscle fibers of pylorus. It causes thickening and elongation with eventual narrowing of pyloric lumen. Clinical features: you have persistent non-bilous projectile vomiting immediately after feeding. So dehydration is there, hypokalemia is there, hyperchloremic it is, and metabolic alkalosis will be there. Vigorous vomiting might lead to esophageal mucosal tear, which is Mallory syndrome, esophageal rupture, which is Boer-Haber syndrome. Then you have palpable olive-shaped mass on abdomen, visible gastric peristalsis there, and greenish stools will be there. Starvation, diarrhea. Persistent non-bilous projectile vomiting. Dehydration, hypokalemia, hyperchloremia, and metabolic alkalosis. pH will increase. Palpable olive-shaped mass, visible gastric peristalsis, and greenish stool. So diagnosis: you can do ultrasound abdomen, pylorus thickness more than 12 to 4 mm, pyloric length more than 14 mm. Barium meal study has string sign, which is elongated pyloric sternum, shoulder sign, which is bulge of pylorus into antrum, and double track sign, which is parallel streaks of barium seen in pyloric canal. Treatment: you have correction of dehydration, correction of metabolic acid alkalosis, and Ramstead pylometry. Hematemesis: you have passage of blood and vomit, which is Coffee ground vomitus, suggests an upper GI bleeding. Etiologically, you have swallowed maternal blood, hemorrhagic disease of newborn, gastroduodenal ulceration, esophagitis due to reflux, portal hypertension, esophageal varices, Mallory syndrome, vascular malformation, coagulopathy, Owen-Schwann and purpura, and foreign body infection. Management is with blood transfusion, drugs you provide, antibiotic prophylaxis, which is third generation cephalosporin, vasopressin therapy, and bacterial. Endoscopic variceal ligation can also be done. Then you have melena, which is passage of black tarry stool, and it suggests upper or lower GI bleeding. Hematochezia is passage of bright red stool in blood in stool. Hematobilia is bleeding from biliary tree, and pseudohematobilia is bleeding from pancreas. Neonatal cholestasis: you have congenital hyperbilirubinemia extending more than 14 days of life. Direct hyperbilirubin is more than 1 mg per deciliter of total bilirubin, or direct bilirubin more than 20% of total bilirubin. Conjugated hepatobilirubinemia, they manifest as dark yellow urine, pale or clay colored stools. Color assessed by looking at core of stool. Outer part of stool has bile stained intestinal epithelial cell. Etiologically, you have extrahepatic, which is substructive cholestasis, and intrahepatic, which is hepatocellular cholestasis. Biliary atresia, most common medial cyst, inspiced bile plug, and bile duct perforation are all extrahepatic obstructive cholestasis. Intrahepatic, you have idiopathic neonatal hepatitis, which is most common, infection by torch, and sepsis. Metabolic disorders, you have galactosemia, alpha-1 antitrypsin, Wilson disease, hematochromatosis, and Neal-Pigmans disease. Genetic, you have Alagili syndrome, Zwillinger syndrome, and hereditary fructose intolerance. Biliary atresia is there, which is characterized by obliteration of extrahepatic biliary tree. Most common cause of obstructive causes, you have type 1, type 2, type 3. You have common bile duct atresia, common bile duct hepatic duct atresia, and common bile duct right and left ducts atresia. Clinical features, you have severe obstructive jaundice, neonatal period, steatorrhea, hepatomegaly, splenomegaly, portal hypertension, and severe pruritus. So for diagnosis, you perform liver function test, conjugation, hyperbilirubinemia will be there, and increased 5 nucleotidase and GGT is there. Ultrasound abdomen, you'll find tubular echogenicity, and IDA scan is normal uptake of drug is there, and absence of excretion of drug due to atresia will be there. MRCP you do, ERCP, and you find multiple strictures in intra and extrahepatic ducts. And then you have percutaneous liver biopsy. Onion skin like periductal fibrosis can be seen. Treatment, you have ROS and Y jejunal anastomosis, which is hepaticojejunostomy. Then you have hepaticoportal jejunostomy, which is Kasai's operation, and liver transplantation is the types. You have left lateral segment donated by adult donor. Auxiliary transplant, you have liver graft is placed in addition to native liver, and orthopedic transplantation, liver is free from dead donor. Biliary atresia is most common indication for liver transplantation in children. Okay. Obliteration of extrahepatic biliary, obstructive cholestasis, common bile duct atresia, common bile duct and common hepatic duct atresia, common bile duct, common hepatic duct, right and left hepatic duct atresia. LFT, you have common conjugated hyperbilirubinemia, increased 5 nucleotide, GGD. USG abdomen, you'll find tubular echogenesis, IDA scan, normal uptake, absence of excretion of drug. Due to atresia, MRCP, ERCP, percutaneous liver biopsy. Lux and Y anastomosis, you have hepaticojejunostomy, Kasai's operation, liver transplantation, left lateral segment, axillary transplantation, and orthopedic transplantation. Okay. Chronic abdominal pain. You have episodic or continuous pain lasting for more than 2 months with absorption of organic causes such as inflammatory, anatomic, metabolic, and neoplastic processes. Pain is termed as abdominal pain related to functional gastrointestinal disorders. Periumbilical pain clearly localized by the child. The mechanism, it is visceral hyperalgesia, which is excessive proprioception of normal gut motility interpreted by child as pain. Okay. Pain perception may be influenced by psychological stresses in home or school. Different types of functional gastrointestinal disorders associated with abdominal pain. You have functional dyspepsia, irritable bowel syndrome, and abdominal migraine. Functional dyspepsia is persistent or recurrent pain in upper abdomen, not relieved by defecation nor associated with change in stool frequency of consistency. Irritable bowel syndrome is abdominal pain associated with change in frequency of stool, change in consistency of stool. Abdominal migraine, you have paroxysmal episodes of normal periumbilical pain with anorexia, nausea, vomiting, headache. Danger signs include serious illness in children with abdominal pain, localized pain away from umbilicus, nocturnal pain, weight loss, bilious vomiting, GI blood loss, persistent fever, jaundice, arthritis, organomegaly, and perianal fistula. Investigations, you have hemogram, ESR, stool examination, urine microscopy, and ultrasound abdomen with swollen lymph nodes. Management is concept of visceral hyperalgesia should be explained to patients. Parents and nutritional diet with adequate fiber should be provided. Pediatric hematology. Anemia is decreased below the normal level of hemoglobin concentration, erythrocyte count, hematocrit, ratio of packed cell volume to total blood volume. I'll continue after some time actually.